absence of the sphenoid wing. So that's another important thing to know with orbital neurofibromatosis. NF1, autosomal dominant, cafe au lait spots, axillary freckling, fibroma molluscum. Those are the skin nodules. Again, sphenoid wing dysplasia, pigmented iris nodules, glaucoma, and optic nerve glioma. So there's, I think, there's all these criteria. There's all these things you have to know about the criteria. So just commit these to memory. I'm not going to go over all of them with you here, but this is something that you guys can study at home. I think it's important to know these because they do like to ask some questions on these. NF2, so these patients typically have hearing loss. So just NF2, hearing loss due to acoustic neuromas around the age of 20. These patients are at risk of developing meningioma, schwannoma, glioma as well, neurofibroma, posterior subcapsular lenticular opacities. Okay, and these patients also are autosomal dominant. This is also an autosomal dominant inherited problem. Okay, so both 1 and 2 are autosomal dominant. Meningiomas or arachnoid villi arise intracranial with orbital extension, and there's typically meningiomas cause hyperostosis, although they can cause bony invasion. Okay, women are more common than men, 3rd to 4th decade. There's a gradual painless. There's no pain involved, so a patient will come and say, I've been losing vision for the past year. It's very classic. Okay, there's also optociliary shunt vessels. Bilateral meningiomas associated with NF. And the shunt vessels, you may get a picture, and this would be minor differential. Okay, so here I think we see a left meningioma. Yeah. So here we can see that the optic nerve sheath should be thickened. All right, and these patients also can present with choroidal folds. There have been reports in the literature of patients just presenting with choroidal folds with the vision of 20/40, 20/50, being sent home and coming back in here with markedly decreased vision, proptosis. And so choroidal folds should also align the differential for diagnosing someone with meningioma. And that's predominantly due to the mass effect that it provides, okay, that it causes. So the triad can be optociliary shunt vessels, disc pallor, and loss of vision. Okay, and here's a better picture. So here we see the optic nerve sheath affected and that typical tram track sign, which you don't see in glioma, so you can differentiate that. You can see the railroad tracks here too. Okay, and these are the shunt vessels. Okay, rhabdomyosarcoma. This is urgent diagnosis. It's an important question for the boards. Embryonal is the most common type, and typically it's supranasal, and 94% survival. Alveolar is the most malignant form. Pleomorphic is the best prognosis. Okay, so if you can just organize that as embryonal, the most common type, alveolar, the most malignant, and pleomorphic, the best prognosis. Chemotherapy and radiation, again, diagnosis, early diagnosis is the key. Okay, so if the kid walks into the ER and you suspect rhabdo, the answer is to find out an early diagnosis. Okay, you may need to biopsy the patient urgently. So here's a patient, a 6-year-old with rapid onset of axial proptosis, and you can see on CT there's lateral and downward displacement of the left eye. The medial orbital mass was proven to be a rhabdo. Lymphomas, 20% of orbital mass lesions. Typically they're monoclonal. It's important to send these for flow cytometry. Okay? They tend to mold in the orbit around different structures. Again, they're also painless, and they provide a mass effect even though they mold. 50% are lacrimal, 17% are bilateral. So just know that you can get a large percentage of lymphomas involving a lacrimal gland. I think that's the key here. Okay. So systemic involvement, systemic disease should also be entertained in any patient with ophthalmic lymphoma. The highest risk of systemic involvement is in a patient that has eyelid lymphoma, and obviously bilateral, but just know that eyelid lymphomas have the highest risk. So those patients definitely need to be worked up. So here's that salmon patch sort of characteristic appearance that should prompt a biopsy. Here we see lacrimal gland enlargement. Okay, bilateral lacrimal gland enlargement. So lacrimal gland tumors, epithelial lesions and dentin displace the globe. 50% are benign mixed tumors, so that there's that rule of 50%, right? So 50% are benign mixed tumors, 50% are carcinomas, and half of those are adenoid cystic. Pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland. It's not painful, and the symptoms are chronic, more than 12 months. There's a pseudocapsule. Incision should be avoided, so don't cut into it because they typically cause a high recurrence rate if you do. So here's a patient that has a proptosis and downward displacement of the left eye, and here we see a pseudocapsule. It's not, but it's in the perfect position. Given his history and lacrimal gland involvement, a biopsy was done. Adenoid cystic carcinoma is the most common malignant tumor of the lacrimal gland. These patients do have pain, and these patients are more acute. So if you differentiate those two, you can answer a lot of questions that way. Secondary orbital tumors can come from paraorbital areas or the paranasal sinuses. Here's a patient with squamous cell carcinoma of the sinus with bony invasion. So again, when you have bony invasion, you want to think about inflammatory disorders as well as carcinomas. Okay. Ethmoid mucocele in a patient here. In the ethmoid sinus, pushing the globe over. As we can see here, it's not very infiltrative, but rather it provides a mass effect, right? Okay, and here we see metastatic disease in a patient that has, again, bony changes. So again, bony changes, think about some sort of inflammatory or carcinoma. This patient had metastatic prostate cancer. So just to summarize, understand the anatomy, categorize the disease processes, analyze the clinical presentation, and imaging. Is it inflammatory? Is it neoplastic? Is it structural? Is it vascular? Is it a deposit or degeneration? Orbital trauma used to have a lot of big incisions and scars. Nowadays, and here's a patient that had a cutaneous incision in the left lower lid. You can see the struts out here and the floor fracture. Large floor fracture, over 50%. So indications for fracture repair: diplopia with a positive traction test after 7 days, enophthalmos more than 2 millimeters, or large fractures, okay, half of the floor or more. Usually within 2 weeks, you want to fix the fracture. And the reason is because there's a lot of scarring in the orbit that occurs, and surgery can be quite traumatic itself if fixing this after 2 weeks. Typically, I like to give patients a dose of a Medrol dose pack or some steroids, and I find that helps them with their edema, their inflammation, and it makes the surgery a little bit easier. Extraocular entrapment is very important in kids. Always don't just go by radiography, go by clinical exam. It's difficult to examine a kid, though, I understand that. Ocular cardiac reflex is important too. Cranial nerve 5 and vagus nerve puts an output to the vagus nerve and decreased sinoatrial node output because of vagus nerve stimulation. So these patients in the ER, when they're hooked up to the monitor, make sure you look at the blood pressure, make sure you look at the heart rate. You'll see bradycardia or junctional rhythms. We had a patient just a few weeks ago with that. Anophthalmic sockets, okay. So four important things to keep in mind is volume, laterality, the fornices, and the eyelid tone. Okay, so evisceration is cosmetically superior to enucleation. Motility is much better, and it preserves the orbital anatomy. Some people say that there's an unknown increased risk of sympathetic ophthalmia compared to enucleation. Some people say it's 1 in 20,000. There are different reports. But we tend to do that very commonly here. Okay, and remember that posterior sclerotomies need to be performed. Anterior sclerotomies, but also posterior sclerotomies. And that question may be asked. They may ask you, well, how do you fit a 22 millimeter implant if you just take the cornea out, right? So you need the relaxing incisions. Those are very important in fitting a large implant. A lot of surgeons like to bring the posterior tenons forward. But I think the important thing to understand is that no tension should be there for the closure, because tension will lead to exposure, okay, and essentially implant extrusion. Enucleation, the entire globe is removed and sympathetic ophthalmia risk supposedly is decreased. Okay. But the cons is it's a longer surgical time, and it's definitely more traumatic to the conj and to the extraocular muscles. So the ideal orbital implant would be biocompatible. It would replace the volume naturally, grow with the patient. We'll talk about why that's important. And motility is very important too. So here's a prosthesis. So what does cause the exposure? Like I said, surgical wound tension. If the implant's too large, conformers, inadequate sclerolaxing incisions, and a rough implant that causes a Velcro effect, although that's not very common. But I think you should think about tension and large implants. Again, infection can also be something that would lead to implant exposure. Socket contraction is very hard to deal with, and that's when there's loss of conjunctiva or a patient has too many surgeries, or when a patient comes in with the Gunderson flap and finally gets referred for the evisceration or enucleation. So why doesn't the prosthesis move? Well, again, there's extraocular muscle damage. So that's why we try to minimize as much dissection. Muscles are out of the normal length tension curve. So here you can see the implant, and you can see that the length tension curve of the muscle has changed with the left compared to the right, and that's why the motility is not as good. Okay, so a lower lax eyelid has this sort of beer belly effect when there's inferior displacement of the orbital content. So you may have an implant in and it may be too heavy, or it may not come forward anteriorly enough. And that lack of direct prosthesis support may contribute to the eyelid having a different tone than normal. Chronic discharge and irritation questions. Think about the prosthesis being too large. Think about an implant infection or abscess, pyogenic granuloma, whether it's after surgery or due to too much exposure and irritation. It's just an inflammatory response, healing response, and protein buildup. Okay, pediatric enucleation is very difficult to deal with. Again, like I said, I'd talk about the entire face relies on the orbital growth. Okay, and if there isn't a stimulus for the orbit to grow, then there's maxillary hypoplasia, facial hypoplasia in general. And those are very difficult things to deal with. So common causes of pediatric enucleation. Here's the patient. You can see he's got left. Essentially, if you divide this line, you can see his nostril may be a little smaller than here. And definitely this entire brow is smaller. Maxillary hypoplasia here compared to the right. Okay, so the important thing to know is that for the eye, 85% of the axial length by age 2. For the orbit, by age 2, there's 70% of the adult size. So the orbit actually lags behind the eye. Okay, it lags behind in growth. So that's why it's important to change out these implants in kids. There's certain implants that expand with injections of saline or some sort of filler, okay? And that decreases the need for surgery because that can be traumatic on the kid. But again, the orbital growth lags behind the ocular, and so that's why it's important to change those implants quickly when needed. Meticulous closure, again, of sclerotenons and conj.